Thank you very much to the organizers of the meeting for inviting me today. I truly appreciate it. Today I'd like to talk to you about a new peptide therapy for hyperpigmentation, hyperpigmentary dyschromias. As you know, hyperpigmentation is truly a global problem that can affect people of all skin types. However, melasma mostly affects females of Asian and Hispanic descent, having Fitzpatrick phototypes 4 or higher. These are the different types of hyperpigmentation, whether they're melasma, post-inflammatory hyperpigmentation, or solar lentigos. So what causes hyperpigmentation? We don't really know the exact pathology of hyperpigmentation, but we know that hormonal fluctuations, inflammation, drugs, and certain diseases can certainly trigger hyperpigmentation. But what we do know is that sunlight plays a major role in the overproduction of melanin, as it increases various factors within the melanocyte cell that can really increase overproduction of melanin. So what are the key strategies for treating hyperpigmentation? There are three key strategies. Tyrosinase inhibition, which involves really inhibiting that enzyme that catalyzes or initiates the production of melanin in skin. Also oxidative disruption, which is simply the use of antioxidants to really disrupt the oxidative environment within the melanocyte cell. And by doing so, you can actually slow down the production of melanin as well. And in exfoliation is very, very important. Why? Because once the melanin granules are deposited in the different keratinocyte cells, obviously they move up into the epidermis, and that's where you have to exfoliate them away to be able to remove the hyperpigmentation. So, of the three treatment strategies for hyperpigmentation, by far, tyrosinase inhibition seems to be the most popular and certainly the most effective way to get rid of hyperpigmentation. The reason why is because tyrosinase plays a role in the first, second, and fifth steps in the melanin synthetic pathway. Today, there are many different tyrosinase inhibitors. Obviously, the most popular and certainly has been considered the gold standard in treatment of hyperpigmentation is hydroquinone, followed by kojic acid, arbutin, polyphenols, licorice root extract, and L-ascorbic acid. However, until recently, peptides haven't really been recognized as tyrosinase inhibitors. So in 2009, a group out of Stanford University published two papers about a technology called decapeptide 12, which is a peptide that inhibits the tyrosinase enzyme. Excuse me. So what is decapeptide 12? Decapeptide 12 is a synthetic peptide composed of 10 amino acids with a molecular weight, or molecular size, if you will, of 1,395 Daltons, which makes it small enough to be able to traverse the stratum corneum very easily. It's a water-soluble peptide, and its recommended use level is 0.01%. Here I present dose-dependent tyrosinase inhibition by decapeptide 12 in mushroom tyrosinase. This is actually decreased intracellular tyrosinase activity in human melanocyte cells, okay, by both hydroquinone excuse me, and decapeptide 12 at equal concentrations of 10 micromolar. Interestingly enough, though, both hydroquinone and decapeptide 12 equally decrease tyrosinase inhibition, but you see here that decapeptide 12 actually decreases melanin content inside the cell better than hydroquinone. So this is a quick comparison against of decapeptide 12 against hydroquinone. Obviously, hydroquinone is a chemical versus a synthetic peptide, which is decapeptide 12. Both are competitive inhibitors to tyrosinase, but decapeptide 12 is 17 times more potent at inhibiting the tyrosinase enzyme than hydroquinone. Okay. The other difference is that hydroquinone oxidizes very easily when exposed to air, water, or light, whereas decapeptide 12 does not oxidize very easily. And finally, obviously, hydroquinone is a skin irritant, whereas decapeptide 12 does not irritate skin. here you can see another assay where you see that decapeptide 12 actually is able to better inhibit the first two steps in the melanin synthetic pathway better than hydroquinone. Now this is a very, very important slide. This is a very, very telling slide. The researchers at Stanford University showed the cytotoxicity profile of hydroquinone versus that of decapeptide 12. As you can see, at 100 micromolar, hydroquinone kills 100% of melanocyte cells, okay? Whereas decapeptide 12 kills no more than 7%. So that tells you a lot about how hydroquinone works, right? Hydroquinone works by inhibiting, number one, the tyrosinase enzyme, but it also is cytotoxic to the melanocyte cell. So it kills the cell in high enough concentrations. Now, you may be asking me, well, okay, you're using 4% hydroquinone. Well, the scary part is that 100 micromoles of hydroquinone here kills 100% of cells. This concentration is 3,000 times smaller than 4% hydroquinone. 3,000 times smaller than 4% hydroquinone, which means that every time the patient uses 4% hydroquinone, there's a good chance that much of that hydroquinone is acting as a cytotoxin towards the melanocyte cell. So it's inhibiting the tyrosinase enzyme, but killing the cell as well. Okay? Whereas decapeptide 12 mostly inhibits the tyrosinase enzyme, but really doesn't cause cell death to the melanocytes. Okay, so the group at Stanford University also designed a clinical study, very small, split-face, double-blind, randomized, placebo-controlled over 16 weeks, that included 5 females ages 35 to 45 of Asian Hispanic descent with moderate to severe melasma and solar lentigos, who had previously failed 6 months treatment with Triluma. Now, Triluma is a product that was sold in the United States previously. As a matter of fact, as of, I believe, October of last year, that was pulled from the market. It's no longer sold in the United States. And essentially what Triluma is 4% hydroquinone, tretinoin, and an anti-inflammatory. Okay, and that's what they used to treat hyperpigmentation. However, in this particular study, we recruited 5, or actually the Stanford group recruited 5 females that had previously failed the treatment with Triluma. So here's a before and after photo, and the right side of the face was treated with decapeptide 12. The left side of the face was treated with placebo. You see some differences there at 16 weeks for sure. We also had 2 blinded, or the Stanford group actually had 2 blinded physicians actually look at the before and after photos and actually rate the improvement from one side of the face to the other. And certainly here you can see that both blinded physicians saw at least a 50% improvement on the side that was treated with decapeptide 12 versus the side that was treated with a placebo. The volunteers also saw very similar results as well. They also rated the side that was treated with decapeptide 12 better than the placebo side, so they also saw a 50% reduction in their hyperpigmentation after 16 weeks as well. They were also very satisfied with the results that they got on the decapeptide 12 treated side, whereas you can see here all 5 patients were very satisfied or extremely satisfied with the results that they got on the decapeptide treated side.